Hi, QD Clinic. Today, no-win consults. What? QD Clinic is brought to you by RheumNow Live. That's RheumNow.live, where we aim to change minds, change practice, and change the way you learn in rheumatology. Lord knows, it seems to be changing. So our case today is a 26-year-old gal. It's a reconsult, an out-of-town reconsult. I don't know about you, but out-of-state consults are either really interesting or really disappointing. They're never mundane. You decide which one this is. She's a young gal who has joint pain, and she's here because she's got a positive rheumatoid factor and a family history of rheumatoid arthritis, and her doctors say she has rheumatoid. So I see her the first time, not on any medicine, has joint pain, sort of odd distribution, like ankles, elbows, hips, not small joint, not symmetric necessarily. Rheumatoid factor was positive. I don't know at what titer, no other test available. So when I see her, really nothing on exam. No synovitis, no stigmata of rheumatoid damage, deformity, etc. And she just has a few tender joints. Doesn't sleep all that well, but doesn't meet criteria for fibromyalgia. I do some blood tests, say come back in a few months. Well, because of life's events, she comes back 6 months later. In that 6 months, she's been put on DMARDs and biologics by her out-of-state rheumatologist, who believed that her rheumatoid factor and family history were enough, along with her complaints, to give her that diagnosis. And she's been on methotrexate and a TNF inhibitor, and maybe better, maybe not. She's coming to me because she's told I'm the guy, so much so that she'll go out of town. She's not really taking any pain medicine, but she has pain. She's not really better, but she's on methotrexate and a TNF inhibitor. So what do you deal? How do you do with these? How do you deal with these cases where you're being asked to be the arbiter of future treatment? The person who should step in and confirm, okie dokie, you're doing the right thing, or no okie dokie, you're not doing the right thing. I find a lot of these patients will come and get a second opinion, sometimes at the behest of their treating doctor, sometimes not, because they got a diagnosis, they're on treatment, but they're doing bad. They feel they're not well. They feel they haven't had a good enough response. They have no confidence in the doctor that's treating them, or they have a questionable degree of buy-in on the therapies that have been offered to them. And they want you to help them make up their mind. What should be easy is us being black and white, us being the expert rheumatologist that we are, being black and white about, do you have the diagnosis? That's my first order of business, confirming the diagnosis with all the facts, if necessary, labs. I don't need x-rays to confirm a diagnosis of rheumatoid arthritis. Second, to assess their response to prior therapy and current therapy. While doing that, you're also making a judgment on the current state of disease activity, whether that merits further attention and change. And then lastly, if they, confirm the diagnosis, have disease activity, haven't responded, you're there to assess, and lay out the best practices that are available to that patient for future therapy. But you got to get over these hurdles. The hurdles of, is it the right diagnosis? Second, have they had an appropriate response? And third, are they being appropriately treated? So, here's the difference, though. I've been around a long time. When I do the math on all the number of joint exams I've done, I started in 1984, so I'm 3 years shy of 40 years, 37 years of rheumatology. I've done probably close to 70,000 joint exams. You can't put my joint exam up against a young doc who's been in practice for a year or two, where at best they're 2,000-3,000 joint exams in, and that's if they did a lot during their fellowship, which they probably didn't. I had the benefit of being forced to do clinical trials from day one in my fellowship. So I've done tons of joint exams, and I used to be a believer in the 10,000 rule, be expert at something, you had to do something 10,000 times. Clinical psychologists have actually shown that it's actually not the number. In fact, the number becomes a surrogate for your conviction and your devotion and your focus on being expert at something. So you might well get there, but if you don't care what you're doing and you do it 10,000 times, you're not going to be very good at it. I think rheumatologists really do care about what they do, and I do think you need to do a lot of them. So my joint exams are different than a lot of the docs who refer me patients, but then again, I've been doing it longer. Am I better? Yes. Am I better than an MRI or an ultrasound? No. But I'll argue that an MRI and an ultrasound doesn't even count, doesn't even matter. Because when you look at treat-to-target regimens based on DAS scores, disease activity scores, and treat-to-target regimens based on ultrasound and MRI, which are much more sensitive, and you're less likely to achieve a remission with those, you don't do better with the imaging and the higher degree of sensitivity to possible inflammation. So a good joint exam is really all you need, is what I'm saying. So again, in this particular case, second time around, joint exam didn't change. A few tender spots, one MCP. That's really about it, but no stigmata of inflammation, swelling, effusion, nodules, deformity, limitation of motion, contractures, nothing. Someone who's had rheumatoid arthritis now for a few years and hasn't been doing well, or maybe a little bit better. Again, the decisions are easy here. And the decisions are what? You need to make the decision on, do you have the right diagnosis or not? And should they stop their therapy? Should they continue their therapy? Should they change their therapy? If they can't get by the first diagnosis, the first point that I made, meaning confirm the diagnosis, well, we're stopping therapy, because what's the point of going on with biologics and DMARDs and steroids and blah, 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 when they're not even being treated for the right thing? If it is the right diagnosis, then you can get into the weeds of continuing therapy, changing therapy, and moving on, or God forbid, transferring care to you, but you're out of state, remember? Kind of far away. These cases are difficult, but I think you should have heard my approach to this. Maybe it helps your approach. Maybe not. Come to Room Now Live and I'll tell you more stories.